Making decisions with multiple people is common in healthcare and is becoming more important with the increasing use of multidisciplinary teams, subspecialization and human factors training. Much of the literature on this subject emphasizes the role of key decision makers and their skills. However, in healthcare, the identity of key decision makers is not usually a prominent issue. Group decisions require the conscious linguistic expression of issues by group members so that others can follow them, and this requires that such decisions are analytic in nature. As for analytic decisions generally, the basic components of group decision-making are situation assessment, option checking, projecting and deciding, and finally reviewing. Group assessment has the advantage that different people have different knowledge of the relevant issues and facts. The points to agree on are the ultimate objective of the decision, the time available to decide, and whether we have the necessary information and expertise or need to seek more. Group option checking usually means different members of the group suggesting different options. This leads to the main disadvantage of group decision making. Options become associated with the person who suggested them. Deciding between them can then become an interpersonal power game rather than an objective analysis of the option's merits. Most of what is said in most meetings is said by talkative extroverts. This is a purely social phenomenon. It does not mean that the extroverts think of the best options. There will be as many good ideas packed into the 10% of time taken by the introverts as there are in the 90% taken by the extroverts. In option projection, the likely results of implementing the various options are assessed. An issue with multidisciplinary teams is that different specialists will be in a position to accurately project different options.
In Accident and Emergency, a patient, now affectionately known as Chuck, used an electric drill in a suicide attempt and damaged his neck severely, including one of his carotid arteries and trachea. Presenting at the emergency department, the drill bit was still present, passing through the skin into the trachea. Medical staff had to deal with the severe blood loss and control the damaged, partially obstructed and bleeding airway. As the drill bit was removed, a wire was introduced into the trachea through the entry wound, enabling dilation and then intubation for airway control. The standard options for controlling an airway are intubation via the mouth or nose and surgical tracheotomy. In this case, there were several factors complicating both options. There was a drill bit passing through the trachea. Blood and swelling were obscuring the surgical and laryngoscopic views. The patient's anatomy was also distorted. Simply removing the drill risked closing the airway and there would be insufficient time to reopen it. The standard options were not attractive, and this therefore prompted a search for alternatives. By placing a guide wire through the wound into the trachea, they were able to remove the drill bit and confidently place an endotracheal tube in the right place quickly enough to avoid hypoxia.
In the scenario mentioned previously of Chuck and his suicide attempt with a drill, a group consisting of an anaesthetist and a surgeon had to solve the problem of a damaged and bleeding airway at risk of obstruction. The anaesthetist was accurately able to project on the oral intubation option. The surgeon was accurately able to project on the surgical option. Between them, they agreed that neither was attractive. Neither of them had previously done trans-wound guide wire-assisted tracheal intubation, but agreed on the projected utility of the option. That is, that it might work, and if it did not, nothing was lost. When the projected results of all options are considered, the decision usually becomes an easy one. In group situations, the skill in choosing lies in assessing the quality and accuracy of the projections, particularly the projections of creative suggestions that may have great advantages but which group members are likely to have little experience of. The role of the group leader is not generally to make the decision, but rather to elicit the best quality options and projections possible from the rest of the group. They then fine-tune these options and projections until one winner is clear. If the group leader makes the decision prematurely, before this process is complete, they are likely to alienate other group members and lose personal credibility, as well as making a poor decision. The nature of group decision-making in healthcare means that reviewing is often not done by the same group that made the initial decision. When a decision about patient treatment has been made by a group, it's a common occurrence that an individual treating clinician will be present when further information becomes available. This allows projections to be updated and possibly new options to be considered. It may not be feasible to take the new information back to the original group. However, the same decision-making processes are gone through again. Research on decision-making looks at the distinction between individual and group decisions. But the things that optimize decision-making in groups are actually part of the related research area of team working. Research into team working looks at team performance and how to optimize it. One such study was done on teams that were using X-ray screening to decide whether or not microscopic cracks were present in aircraft wings. The results were particularly interesting. In this study, high-performance teams missed few cracks that were there and made few false calls about cracks that weren't there. Lower-performing teams missed more cracks and made more false calls. Researchers measured the performance of whole teams and also measured the performance of individuals within teams. Individuals joined teams, left teams, and moved between teams during the course of the study. New members joining a high-performing team tend to quickly gravitate to high levels of performance. In contrast, in the poorer teams, new members tend to quickly gravitate towards the group's lower norms for performance. Interestingly, some who performed well in effective teams also gravitate towards the group norms in poor-performing teams. In effective teams, their performance tends to rise and bring everyone up to the same high levels. However, in teams that are underperforming, members drift down to lower levels of personal performance.